So going into the HPI for the case. So a 24-year-old previously healthy woman presented with a 1-month history of fatigue, hair loss, subjective fevers and chills, malodorous urine, and unintentional 10-pound weight loss. Over the past month, she also had 3 episodes of non-bloody, non-bilious vomiting, non-bloody diarrhea, blurry vision, and a tingling sensation in bilateral toes. She's also had a slight decrease in PO intake, but not significantly so. And then she denies headache, sore throat, cough, chest pain, abdominal pain, leg swelling, bleeding, or easy bruising. So if with your neighbors, you would take 2 minutes, I'd like to ask you to discuss what 3 additional questions you want to ask and why. Certainly you would ask more questions than 3, but I want you to prioritize the top few things that you really want to get further on history. So I'll give you guys 2 minutes. So let's have what I'm going to dub as table 1 over here to my right. If you guys would talk me through what are 3 questions that you want to ask this patient on further history.
So without first being complete infectious, so like maybe any recent travel.
Great. So concern based on the kind of consortium of symptoms that maybe there's some kind of infection going on. Different infections tend to come from different places. And so finding out about any significant travel history. Excellent. Completely agree. What else did you guys come up with?
Sexually active.
Okay. Sexual activity. What is prompting you to ask that question?
A lot of the symptoms, some of these symptoms are not specific to you see in the pregnancy. Also malodorous. See if you could have a kind of STI. I mean, obviously it's very low on those possibilities.
All right. So young woman, childbearing age, possibility that she could be pregnant. So asking about that possibility. And then some of her symptoms, although many are non-specific, some of them could be consistent with certain sexually transmitted diseases. So kind of screening for that, taking a good sexual history, completely agree with that as well. And let's take the pressure off of table 1 and ask table 2 here in the middle if you guys had a 3rd or maybe even 4th question in addition to theirs.
I think if she's having dysphoria.
Okay, so asking if she's having dysuria along with the malodorous urine. Why are you asking that?
Fever, chills, malodorous urine.
Yep, so trying to kind of put everything together. Maybe this is a UTI, another symptom of a UTI that we didn't talk about in this HPI that I gave you is dysuria, so screening for that. Any other big things you guys wanted to ask about?
Sounds the vague systemic symptoms sound kind of endocrine in nature. So
okay.
Asking about family history, autoimmune diseases, type 1 diabetes, a cold, heat intolerance.
Okay, so some of the vague systemic symptoms may be suggestive of either an endocrine problem or an autoimmune problem, and so screening for probably a personal history of any of those diseases, because we haven't gotten into past medical history yet, but also a family history as well, as some of these things tend to run in families, okay? Great, awesome. So let's move on to the next slide. Let's give you guys some past history. No known medical issues is her past medical history. No medications, and you can assume that that means no over-the-counter stuff, no supplements, no remedies from the internet, but those are things you sometimes have to explicitly ask about. No prior surgeries. Family history, no known medical issues in the family. And then social history, she lived in Mexico until 1 week after symptom onset. So the symptoms kind of started, she was kind of feeling bad, and then she came to Denver, and they continued. No tobacco, alcohol, and drugs. She is monogamous with her husband. And then moving right into the physical exam. So she has a temperature on admission of 36.8. She's a little bit tachycardic. Her respiratory rate is, I wouldn't call 19 normal, but it's not super high. And then her blood pressure is a little on the low side, kind of unclear what her baseline is. Maybe this is where she lives. Maybe this is like much lower than she lives. You don't know that yet. And then she's sitting at 96% on 2 liters. I put the 2 liters in red because if they just put oxygen on her, fine, all fine and well. But if she's actually needing 2 liters, that we can all agree that's not normal in a 24-year-old. She's learner-oriented ×4, no apparent distress. On her HENT exam, she has thrush in her mouth. And then cardiovascular exam, she's a little tachycardic, which we already knew, but it's a regular rhythm, no murmurs, rubs, gallops. Her lungs are clear. Her abdominal exam is unremarkable. So normal bowel sounds, non-tender, non-distended, no appreciable hepatosplenomegaly. Extremities, no cyanosis, clubbing, edema. She is noted to be pallid. And then on neuro exam, for the neuroprelims in the room, this is an internal medicine doctor doing the neuro exam, but we did not appreciate any neurological deficit. So I want to talk quickly about the concept of sick versus not sick. If you've seen some of my talks earlier in the year, you may have seen this exact slide. You definitely, if you went through medical school, heard about this concept before, but oftentimes we're asking you if a patient is sick or not sick. This is actually an expected skill to have as a 4th-year medical student. So we expect you guys to come into residency knowing how to evaluate if a patient is sick versus not sick. And what does that mean? You know, I have a cold, my tummy hurts, am I sick? Well, this is what we mean by it. A patient is sick when emergent clinical intervention is required to preserve life or limb. And then determining a patient is sick is a pivotal moment in a case. It's a little bit scary, but it's also reassuring because at this point, your attentions and efforts shift from diagnosis to management. Now, you still may have to do some diagnostic work to figure out how to manage the patient, but determining that weird zebra diagnosis that may come in the days and weeks to come is not necessarily as important as managing the patient and preserving life or limb. And when in doubt, call for help. I would say especially during the first part of intern year, but I don't think we have any, well, no, we have Dr. Amin here. So 3rd-year residents in the room can attest that even when we're on overnight, especially when we're in the Denver Health MICU, where there's no fellow or attending in-house, when we have a sick patient, we're usually calling our fellow R3 to the bedside, just having 2 brains at the bedside to think things through. So when you identify that a patient is sick, it shouldn't just be you, and the bedside nurse. You should probably be at least bouncing some ideas off of other people. So here's the physical exam. Now we may find out more information or the patient may change their course or whatever, but would you classify this patient as sick or not sick? Is clinical intervention required at this time to preserve her life or preserve a limb? Okay. So I would agree. I wouldn't classify this patient as sick. Now, senior residents in the room, is this person like someone who's like kind of a little bit on your radar, like a previously healthy 24-year-old who has some vital sign derangement? So not someone who you want to like round on in the morning, not checking in all day, and then just come see the next morning. Like something fishy's going on.
She's admitted to the hospital at this point, right?
Yeah, she's being admitted to the hospital. Well, she's in the emergency room on her way into the hospital, which we're about to hear about. But just based on this information alone, what do you think? Sick, not sick?
Go take a look at her.
Yeah. Yeah, so not decisively sick, but keep an eye on her. Things could change. Here's some labs for you guys. I was feeling generous and I highlighted things that I considered to be abnormal in red. Okay, so looking at that sodium, bicarb's a little bit low. That protein is high, especially relative to the albumin. Okay, so there's a bit of a protein gap there. And then transaminases and alk phos are both a little bit elevated. And then wow, who was expecting a hemoglobin of 6.9? Dr. Stacy, if you see a hemoglobin of 6.9 and you were not expecting it, what might be your next step if you were not expecting it?
Recheck.
Yeah, you want to recheck it? Okay. So we rechecked it. It was a little bit lower. Okay, in a different universe, we would have rechecked it. It would have been 12. There would be no, clinical evidence of anemia, and would be like, probably lab error. But we rechecked it, and here it is, 5.8, MCV of 81, elevated red blood cell distribution width, which is usually the case when we're cranking out immature red blood cells, like trying to keep up. Okay.
Did you get her
She might have got some glutes. I'm not sure, but she might have. But usually you're not going to. Why are you asking, Dr. Beam? Why are you asking if she got her? Yeah. So astute observation that at least 2 cell lines are going down. So it's not necessarily showing that her hemoglobin is downtrending per se. She could have got some IV fluids, could have diluted out a bit, but probably not a baseline hemoglobin of 13 that is getting fluids and then diluting out to 5.8. So she is, I think we've confirmed the diagnosis of anemia. And then they got a diff on this second one. And the only thing that stood out is she had an absolute lymphocyte count of 0.49.
Is that high or low?
That is low. Yeah, good question. Next general concept I want to talk to you guys about, and I think a lot of people in this room have been in one of my talks before, but problem representation. This is an important concept, okay? So for those of you who don't know or want a refresher, problem representation is a 1-sentence summary that highlights the defining features of the case, okay? It is not a regurgitation of the HPI, but it effectively and succinctly answers 3 questions. Who is the patient? What is the time course? And what is the clinical syndrome? And a couple things I want to say about problem representations. One is that why are we doing this? It's because it's a launch pad for you to then move on to your next steps, right? So when you are able to frame the problem, you can't come up with a solution, a good solution unless you frame the problem. So this is us in clinical medicine framing the problem with a problem representation. The other thing I want to say about problem representations, we're only going to do it once for the purposes of this talk, but your problem representation changes as the case evolves. So you may have a problem representation just based on the HPI, and then you get labs, and then you get imaging, and then you get the biopsy and pathology or whatever you get. And the problem representation changes at each step, okay? So I want you to get back in your groups, and I want you to take a minute to develop a problem representation for this patient, and I will put up the labs for you guys so you can take a peek at them. And we'll give you guys a minute. All right, bring it back together. Let's have table 3 over here. Just give us your problem representation for this patient.
We have a 24-year-old, previously healthy, living in Mexico, coming in previously at baseline, coming in with like a month of progressively worsening, seems like general malaise, mild fevers, non-specific GI symptoms, and also non-specific neuro symptoms. Also found to have really severe anemia, hepatobiliary markers, elevation, non-elevation, also due to osteoporosis.
Awesome. So really nice job there, kind of describing what we call the background, which is young, previously healthy, from Mexico. And then I think you mentioned the time course in there, and then really good job kind of summarizing a pretty complicated foreground. Now, this is going to be stylistic. It's all going to be happening in real life in your own head, so it doesn't really, matter most of the time, but sometimes you're going to consolidate things, like I noticed you did with non-specific GI symptoms, which I totally agree with saying, whereas sometimes we'll have like, someone with exertional chest pain that gets better with rest, and they have a bunch of cardiac, you may say this is cardiac chest pain, and you may be really specific. So sometimes we generalize, sometimes we group. And I think you did a really nice job of that. So not a right or wrong answer. This is what I came up with. at just about 6 o'clock this morning when I was finishing this talk. So bear with me. So I said this was a previously healthy, young, non-pregnant woman from Mexico, okay, presenting with subacute and progressive. And you could say this is a little lazy, but this is what I came up with. A multi-systemic symptoms without a clear syndromic pattern. Okay? There was nothing to me in her symptoms that said, oh, this is, pleuritic chest pain, or this is right lower quadrant pain, or something like that. She just had symptoms all over. Remember her toes were tingling? Like, who knows what's going on with it? Multi-systemic symptoms without a clear syndromic pattern, and found to have thrush, which I thought to be important in a previously healthy 24-year-old, a protein gap, elevated liver enzymes, profound normocytic anemia, and lymphopenia. Okay, so still quite a complicated case, but hopefully this feels like a little bit better than that first HPI where things were all over the place. That first set of labs where it's like, oh my gosh, so much red on the screen. Now we can work.
Jason commented on some of the things that are problem representation.
Yeah.
This is pretty great. I think for me, a problem representation is always what's the best differential building tool. So like where you mentioned thrush and lymphopenia, what you want to be walking away with this is not those data points, but that there's signs of immunosuppression.
Yeah.
Right. So just as you say, you consolidate factoid and collecting your HPI and your objective data into a synthesized term that represents a differential in your mind or sways a differential. So you take something like 1 month and you turn it into something cute, or you take something like thrush and lymphopenia and you turn it into signs of immunosuppression. And that way, it starts to persuade you into different differential banks or away from them.
Yeah, could not agree more with that. That's the whole point of a problem representation. So that's like even a next step that you can consolidate this further. Why did I think that thrush was important? Why did I think lymphopenia was important? Well, because actually in my mind, subconsciously, I was like, oh, this person might be immunosuppressed. And actually in your problem representation, you can simply say showing signs of to suggest, underlying immunosuppression, okay? People can always ask you, well, what do you mean by that? Then you can explain. But in your mind, now you're working off a differential of a young, previously healthy person that has a bunch of stuff going on in addition to signs of immunosuppression. Awesome. So now that you have this problem representation, take 2 minutes with your group and think about what test you might want to order. They're being admitted. Let's come on back together. And I'm going to ask table 1, it's back to you. What are some tests that you're thinking about ordering as you're admitting this patient to the hospital? And give me like a half liner of why for each one. Okay.
Urine antigen, urine antigen, crypto, beta glucan, EBV, and then ferritin. We also talked about how we can use it to like figure out if there's some like crazy immune response going on.
Perfect. So I'm gonna kind of summarize what I heard as best I can, fill in what I missed. So looking at HIV, looking at TB, looking at, I heard HSV, doing a good anemia workup. So what we mean by that is looking at iron studies, looking at, I think you said a peripheral smear. What's that? Reticulocytes, okay. And then a chest x-ray, abdominal imaging, and then a bunch of fungal serologies as well, and some viral studies with like EBV, maybe CMV. Cool. That's pretty good. That's not bad for like a admission workup, but does anyone else have anything that they feel very compelled about ordering on admission to the hospital?
Go for that.
So viral hepatitis panel, obviously liver enzymes are up a little bit. And then why TSH?
The systemic symptoms, the hair loss.
Yeah. Anytime something's funky going on, you're never wrong in just checking a TSH. Thyroid, whether it's overactive, underactive, can do some really just bizarre things in the body. So not a bad idea. Actually, some would say a really good idea. And then table 3, you guys have any other things? It's a pretty thorough workup. Perfect. Okay. So we're all on the same page. Let's give you guys, I don't know if I have all of that, but I definitely have some of that. Peripheral smear, 1+ anisocytosis, 1+ dacrycytes, 2+ elliptocytes, 1+ hypochromia. Well, the 1+ hypochromia kind of suggests, some lower iron. The rest of the stuff, there's a few different things that can cause any of these things on the smear, not specific to any specific disease, okay? No schistocytes though, okay? Here's some more labs. So LDH is up at 275, just slightly so. Haptoglobin, which as a reminder in hemolytic anemia, we're expected to be really low. In this case, it's up, it's undetectably high. Fibrinogen is also a little bit high. D-dimer is high. INR is 1.2. CRP is 95, okay? Ferritin is quite high at 1,475. And then iron is really low with a saturation that's also low. And then the TIBC randomly is pretty normal. B12 is normal. TSH is normal. And actually looking down this left column, I don't want to go off too much of a tangent, but these are a lot of tests that we often order. And I want you to reflect on some of them, like, are they really helping you? Even though they're abnormal, like, are there things there that are really helping you? Maybe some of them are, but certainly not all 7 of those abnormal tests, 8 if you include the smear, are helping you. So just remember that when you're actually picking out the tests you want to order, what are you going to do when they're abnormal? How is that going to help you diagnostically? Liver enzymes were up a little bit, so they checked Tylenol, undetectable. They checked alcohol, which was also undetectable. SPEP. I thought whether or not to keep this differential in there, but the pathologist gave it to the admitting team, so I'll give it to you guys too. Hypoalbuminemia with polyclonal increase in gamma globulins consistent with chronic infection, collagen vascular autoimmune disease, granulomatous process, chronic liver disease, HIV infection, or other chronic inflammatory process. So definitely doesn't narrow you too much, but there you go. And then UA. So a lot of red, but let's dissect it. There's some white cells, nitrites are negative. Remember, only certain bacteria convert nitrates to nitrites, and you need to be sitting in the bladder for 4 hours for that conversion to happen. A little bit of protein, some red, some whites on the actual count. And then moderate squamous cells, so maybe we're a little bit contaminated. Many bacteria, some hyaline casts, a couple of granular casts. Urine and blood cultures are sent and are pending. You guys want a chest X-ray? Normal or abnormal? Yeah, so we won't go through the whole like systematically breaking it down. We'll save that for a pulmonary conference. But basically they noted extensive bilateral, tiny reticulonodular opacities, and then superimposed patchy right middle and lower lung zone opacities, non-specific, but can be seen in atypical infections. So fungal pneumonia, miliary TB, and then non-infectious processes such as sarcoid, hypersensitivity pneumonitis, and pneumoconiosis. All right, okay, starting to get a little bit interesting. I had your curiosity. Do I not have your attention? Again, not going to scroll through the CT, but this is kind of a representative shot from the CT, chest, abdomen, pelvis that was done. And basically down in that right lower lobe, there was a pretty dense consolidation, multiloculated cavitation, okay? And then scattered randomly oriented pulmonary nodules throughout the lung, okay? Concerning for a highly aggressive pneumonia, maybe an atypical aggressive bacterial pneumonia, maybe TB, maybe pneumocystis pneumonia in someone who has HIV. Additional consideration includes fungal pneumonia, and then had some hypoattenuating hepatic lesions, non-specific, Maybe if there's some systemic infection, these are abscesses, who knows? Even though malignancy isn't super high on our differential, like these could be metastatic lesions. And then these enlarged lymph nodes throughout the mediastinum and retroperitoneum, likely reactive in nature. More labs, things that you guys wanted. You didn't ask for COVID. Come on, guys. What have we taught you over the past year now? So COVID is negative. Remember, they're having diarrhea. C. diff is negative. Blood parasites and malaria screen were negative. Hepatitis A, IgM negative, but the total antibody positive. So for those of you who know, this is consistent with a prior exposure to Hep A, but not an active infection because they don't have the IgM.
Could this also be just vaccinated?
Yes. Yep. Good point. Hepatitis B, surface antigen negative, hepatitis surface antibody negative. So most of the time, this will mean that the person has not been exposed, not been vaccinated. The alternative is, well, I guess you could be really old and your vaccine wore off. You could have this pattern. The other possibility is you're in that window period of an acute infection, in which case you check a core antibody, which would be positive, but they did not check that in this case. And then Hep C antibody is negative. HIV screen was positive. And then HIV-1 antibody was positive with a quantitative RNA of 220,000 and some change. HIV-2 antibody negative. And then the CD4 count was 51. And the percentage was 10% of T cells, which is low. Pop quiz, in acute illness, does the CD4 count reliably go up, reliably go down, or there's no relation, it just does whatever it does? What do you think?
In an HIV patient?
I don't think they're, in all fairness, I don't think they're checking a lot of CD4 counts in like the, normal patient population. We'll just say in an HIV patient for simplicity, but it's probably true in a non-HIV patient too. You have a 33% chance.
Down.
Yes. In acute illness, the CD4 count reliably goes down. So the reason this is important, if you have someone who's on ARD and they have relatively well-controlled HIV, maybe they're on their way towards being a negative viral load, and their CD4 count is like 400 or something. You may see in acute illness that their CD4 count is 220. That may not represent like a progression of HIV, that just may mean they're acutely ill. So that's why in an HIV patient who's acutely ill, it's also important to look at the percentage, which is a much more reliable indicator of the CD4 count being low. Now, 51 is very low. It's well below, like kind of the 250 threshold of what we consider like having your normal cellular immunity. So that absolute count is probably convincing enough, but then it's confirmed in the setting of acute illness by looking at the percentage. Okay. More stuff. Urine strep Legionella, strep and Legionella antigen negative. A sputum Mycobacterium TB PCR was negative, at least one. 1,3 beta D glucan was positive. I think Dr. Amin mentioned getting that. What is that?
Found out from 1G's indication of infection.
Yeah, so this is kind of the screening test. 1,3 beta D glucan, trade name is Fungitel. And this is basically indicative of an invasive fungal infection, not otherwise specified. So it doesn't nail down a diagnosis for you. There's some scenarios where you can have false positives. You can certainly have false negatives. But this is suggestive of perhaps an invasive fungal infection. So here's some fungal studies. Serum histoplasma antigen negative, serum cryptococcus antigen negative, serum coccidioides was positive, 164 titer. And then the blood culture was positive for mold. And they commented, no further testing can be performed to rule out mycobacterium species due to coccidioides overgrowth. Okay. So as a reminder, these are in the, I guess, middle part of North America. We're cutting off the top of Canada and the bottom of Mexico. But this is the geographic regions where the endemic fungi are endemic. And that kind of yellow greenish at the bottom of the screen, that's covering a fair amount of Texas, New Mexico, Arizona, Nevada, and then going into California. That's where Coccidioides is endemic. And then if this map were bigger, you would see that it's also endemic for much of Central America and parts of South America. So really anywhere that's dry, that's arid, that's in the Western hemisphere, Coccidioides can be there. Okay, now look at us here in Colorado. No endemic fungi. Well, don't we feel left out? The thing is, people tend to travel, to Colorado from other places. So taking a good travel history, not totally having these fungi off your radar just because you're living in Denver.
So fun fact, had a guy with AIDS with disseminated disto that he picked up in West Africa, which is where he's from. It's apparently endemic there too. So worldwide, there's like other fungal patterns that are also endemic.
Yep, so Dr. Amin's pointing out that he took care of a patient in West Africa who had histoplasmosis because it's also endemic there. There's a whole wide world out there outside of the United States of America that we should be aware of. Just as a side note, wanting to know what's endemic to different countries, the CDC has an excellent website where you can plug in the different countries and basically show what infectious etiological agents are endemic to that region. Okay, nice. Let's talk about, this has one more syllable than I thought it did, but this is the right word. I checked many times. So coccidioidomycosis. Its slang term is valley fever. It's caused by the dimorphic fungus Coccidioides, and there's two species, but they clinically behave the same. So it's not really important to distinguish between those two. The mold in endemic regions is ubiquitous in the soil, and the spores are famous for kind of levitating in the air for long periods of time and then getting really deep down into the airways of hosts. Most immunocompetent people, if you take a nice breath of Coccidioides spores, you're going to have like a subclinical infection that your immune system is going to clear. But if you get infected by it or you're immunocompromised or something like that, the most common presentation is a primary pulmonary infection. When you have a pulmonary infection, you usually have unilateral dense infiltrates and ipsilateral hilar adenopathy. And then this is one of the bugs that's classically associated with upper lobe disease, okay? Kind of like TB and a couple other things. It's often also associated with non-specific systemic symptoms, much like our patient. And then interestingly, for those interested in rheumatology or dermatology, it commonly presents with rheumatologic symptoms. So you can have some non-specific arthralgias and cutaneous manifestations, erythema nodosum and erythema multiforme. So you have an HIV patient who has new erythema nodosum and they're not well controlled. Think about Coccidioides. Same with erythema multiforme. Who is at risk of having severe or complicated disease? So major suppression of cellular immunity. So poorly controlled HIV, post-transplant, high dose glucocorticoids, the folks on anti-TNF alpha therapy, hematologic malignancies, chemotherapy associated cytopenia, and then pregnancy. So pregnant patients are at pretty high risk of having severe complicated disease, especially in the second and third trimesters or immediately postpartum. And what does severe disease look like? So if someone has infiltrates on both sides of their lungs or more than half of one lung, like our patient, that's bad. If they have symptoms that include night sweats for more than 3 weeks, that's bad. If they've lost more than 10% of their body weight, that's bad. And then if they have antibody concentrations greater than 1 to 32, then that's bad. How do you treat this? So mild, moderate disease, you breathe in some Coccidioides spores, you have a little bit of a cough. You can just like manage it conservatively if you have a functioning immune system and you're not pregnant. However, if you have severe disease or immunocompromised pregnant individuals with any severity of disease, the treatment is fluconazole. The standard is kind of 12 weeks. Sometimes they shorten there's some studies to show that 6 weeks might be sufficient. And then if you have someone with really complicated, prolonged refractory disease, sometimes they extend it out to up to 24 weeks. And then some people who have poorly controlled HIV who live down in an endemic region, sometimes they'll have people even on suppressive therapy or like prophylactic therapy. Itraconazole is an acceptable alternative, but it has a worse side effect profile. And then for folks with really severe disease, once they have respiratory compromise, then amphotericin B is first line. And then these folks tend to have long-term sequelae, especially if they have severe disease. So you want to follow them up for about a year afterwards, mainly looking for pulmonary complications. So hospital course and case resolution. And this, I will warn you, it is a little bit sad. This was a pretty tough case. So the ID team came and they did an ID level history. And they found out that she was actually diagnosed with HIV peripartum 8 years ago. She acquired it from her husband. Her husband does not, did not know how he got it. And then she had been off antiretroviral therapy because she was on it briefly and had intolerable side effects, not really sure what they were. She had been intermittently traveling between Denver and Mexico because I think one of her kids was a US citizen, one was a Mexican citizen, had to kind of move back and forth between the two. She was having fatigue, night sweats. She was having fevers, chills, productive cough. She had actually lost 30 pounds over the past month. So sicker than we thought on the nose. The initial concern by the admitting team was that this was miliary TB, and they empirically started her on RIFE with the guidance of infectious disease. And then they also initiated antiretroviral therapy. Unfortunately, on hospital day 5, she developed rapidly progressive respiratory failure and was intubated. And there was some theory that this may have been an iris or an immune reconstitution inflammatory syndrome. So what that means is you have some infectious agents in your body, but you have no immune system, so you're not mounting that big inflammatory response. You get on antiretroviral therapy, your immune system comes back, massive inflammatory response, and you can get pretty sick because of it. So it doesn't represent a new infection, but rather a new body response to an infection. This is why people who have HIV and have CNS or AIDS and they have CNS infections, they actually will hold off starting antiretroviral therapy for a while because iris in the brain is really, really bad. Coccidioidomycosis was ultimately diagnosed. TB was ruled out by bronchoscopy, and RIPE was discontinued. Amphotericin B was started. She had progressive ARDS and refractory shock, and the patient passed away 4 weeks into her MICU stay. So this was a tough case. A lot of our residents took care of this patient, and she was 24 years old, so really, really sad. Studies returning after her death actually confirmed a diagnosis of hemophagocytic lymphohistiocytosis, or HLH. So HLH, as a reminder, is the sequelae of an underlying infection, malignancy, et cetera, et cetera. She met 5 of the 8 diagnostic criteria. She had fever, she had a high ferritin, she had hypertriglyceridemia, and then these send-out tests came back after she passed away. Low natural killer cell activity and elevated soluble IL-2R or CD25 levels. The other criteria, in case you're wondering, is splenomegaly, anemia plus thrombocytopenia or neutropenia, or hemophagocytosis, which is basically white blood cells eating red blood cells on a bone marrow biopsy. So she didn't have the first 2, and then she was never stable enough to do a bone marrow biopsy. And then as far as like empirically treating it, she had already been on high dose steroids related to her respiratory and infectious status. They did not offer empiric etoposide, which is the other kind of chemo medication they use for HLH, because they were concerned of bottoming out her white blood cells and making her response to the infection even worse. So sorry to end on kind of like a bummer note, but a lot of kind of good teaching points in this case that we can all learn about. Does anybody have any questions about this case?
Anemia was purely because of the HLH.
We think that it was related almost an anemia of inflammation, of chronic inflammation. There was not an alternative reason that was discovered. The pattern was kind of consistent with that. And it didn't get really worse with the HLH, so it may have just been the inflammation from the initial disseminated coccidioides. Good question. All right, guys, I'll stick around afterwards, but that's all I got. Thank you for listening.